Good afternoon to all our listeners. It gives me great pleasure to introduce Dr. Rajiv Jauhar. He's currently the Associate Professor in Cardiology at Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He's the Chief of Cardiology at North Shore University Hospital. He was the Director in the Cardiac Cath Lab and Interventional Cardiologist at Long Island Jewish Medical Center. He holds many administrative leadership positions and is a member of many cardiology-related societies and organizations. He's also the founder of Long Island Fellows Society, received many honors and awards, has 32 publications to his credit, and is involved in numerous funded projects. In addition, several abstracts, poster presentations, and exhibits, approximately up to 60 in number. I can go on and on, but in the interest of time, I would like to invite Dr. Jauhar to present this important information that affects every Indian household. Dr. Rajiv Jauhar.
So like we treat diabetics, we should treat South Asians more aggressively. So if I take myself, a 55-year-old gentleman, and I take a similar 55-year-old white male with a similar weight and other risk factors, I have to be more aggressive with my diet, my exercise, my stress relief, because the reality is that I am at increased risk of heart disease. And this has been a problem that we've talked about for years. My brother published an article in the New York Times about this several years ago. And we've been starting to do some research on this. I think this is my favorite name for a trial called the Masala study, which is coming out. It's called the Mediators of Atherosclerosis in South Asians Living in America, the Masala study. And it tells us that we have 60%, 60% of all the heart disease in the world are people of South Asian descent. That is a bit numbing, right? 6 out of 10 patients who have heart disease in the world are our people. And so we have to be very cognizant of the issues and things that we can control. We cannot control our genetics. We cannot control where we were born. We cannot control our parents, but we can control other factors like exercise, diet, stress relief, etc. So this gentleman presented to me several months ago, when he presented to an outside hospital with chest pain. Now, why am I showing you this film? He came in with ST changes. He had chest pain. Not everyone on the call can read EKGs, but the reality is that these bumps are not good. This is ST elevation. This is a classic myocardial infarction. We brought him urgently to the cath lab. He had a closed artery, left anterior descending. I opened it up. His heart function took a huge hit. As you can see, this part of the heart is not moving. I fixed it. He did great. So why am I showing you this picture? I mean, I do this several times a day. Well, and this is the clot we pulled out of his artery. Remember, a heart attack is a natural, normal phenomenon to an unnatural event. If I go in the kitchen and my wife doesn't let me in the kitchen anymore because I have 10 thumbs. And so if I use a knife and I cut vegetables, for example, and I cut myself, I bleed, right? And I bleed and my body tries to stop the bleeding. When there's a cut in the arteries to the heart, the body's natural response is to stop the bleeding with platelets, coagulation factors, and everything else. But that in a 4 millimeter, the heart arteries are 4 millimeters in diameter, 3 to 4 millimeters. So that natural attempt to stop the bleeding causes the plugging of the vessel. So why is this patient different than what I normally do? Because he's 19 years old. He's a South Asian, is a second-year college student in Queens, and he had a heart attack. And we've seen this more and more frequently among our people. I can tell you that, living in this community where we have such a huge South Asian population of Indians, Pakistanis, Bangladesh, Sri Lankans, and then the Guyanese population that emigrated about 150 years ago to Guyana, and they live in the Richmond Hills area. There's a huge problem. For those of you who don't know, Richmond Hills has is the highest diabetic zip code in the country. So clearly we're doing something wrong, the things we can control. So people say, well, you know what? My LDL is great. I don't need to worry about it. My LDL is perfect. But even in the studies, we found that achieving LDL goal in major trials did not really affect that much event rates. And so the treatment for any ethnic group needs to be tailored. We have to stop doing studies on white males and then extrapolating all that data to Indians, women, African Americans. We need to tailor our studies to specific ethnic groups because, genes load the gun, but lifestyle pulls the trigger in us. And so we have to sort of affect our lifestyle as much as we can, because even if we have a normal cholesterol, and you will very rarely find an Indian, and when I say Indian, I mean South Asian. You very rarely you find an Indian with dramatically elevated cholesterol. You very rarely will find an Indian with a cholesterol above 250 or 300. We normally live in the range where I lived a year ago, about 210, 220. But we have a low HDL. HDL is our good cholesterol that sort of takes the cholesterol from the body and brings it back to the liver to absorb it. So cholesterol in and of itself is not the end all be all. And why do I say that? Because in our Framingham study, they showed that 35% of people with heart disease occurs in people with normal cholesterol of less than 200. So if you have a cholesterol of 180, and I bet people on this call have a normal cholesterol, it does not make you immune to heart disease. So like I said earlier, we have non-modifiable and modifiable risk factors. We can't affect our age, no matter how hard we try. Botox does not affect our age. Can't really change our gender genetically, and we can't change our family history. But we can modify risk factors. You know, when I see so many of my patients who have heart disease smoking, that's pulling the trigger, you know, or patients of mine who, you know, or have high blood pressure, and I meet them at the Indian restaurant, and I see them eating what they're eating, and I'm like, you know, and I don't say anything, although they always are embarrassed when they see me. And that's why I said at the beginning, I do not own an Indian restaurant. But the reality is that, you know, we have to sort of take care of ourselves. I see, and all the physicians on the call, you see a patient maybe twice a year, maybe 3 times maximum. The other 362 days, they're on their own. And they have to sort of, people have to be held accountable to their own health. And that is what is most important. Because we have to go beyond cholesterol in the 21st century, beyond lipids. We have to look at risk factors, the behavioral aspects of it, the inflammatory aspects, the genetic aspects. These are all very important. And I love this slide because, you know, waiting until chest pain to take action is about as dumb as waiting for labor pains to begin prenatal care. You have to start early. And we know from many studies from the Vietnam War on boys and girls who died at age 18, 19 in the Vietnam War, that when they did autopsies on these people, they started developing coronary atherosclerosis at age 18 and 19. So it's never too early to start. You know, it's never too early to start with the low-fat milk. It's never too early to start with exercise. You know, it's never too early to take away the sugary drinks that we have and that our kids drink. It's never too early to start to eat more fruits and vegetables and less processed meats and food. Never, ever too early. So what about our people, right? What about the Desi people, right? I assume the majority of the people on this call are of South Asian descent. And India didn't really appreciate this until over the last several years, where now it's become in social media, in the newspapers, where, you know, India is staring at a killer lifestyle epidemic, you know, and that's a huge problem because, you know, in a typical day, this is what we normally eat, right? Whether you're eating at home or eating out, it's more of a cream-based diet, more carb-based, more sugary-based than the typical protein-based diet that we see in the United States. And salad is probably not, except for a small minority of people, is not the primary mainstay. And this premature cardiovascular burden is not immune to gender. Men and women both have disability based on life years lost. And if you look at it, men and women, South Asian women have more disability of life years lost than any other group, period. And that's a huge problem. And there's been absolute increase in the last 30 years about uh, years of loss to disability in people with ischemic heart disease. And that's a huge, huge problem. And that does not, it's agnostic to location. So whether you're from South India or North India, whether you're a first generation immigrant or not, you're not immune. Whether you're a woman or a man, you're not immune. Women get heart disease. It's a problem. Whether you're young or old, that 19-year-old boy, he developed heart disease. We see the highest mortality in young people because they deny the fact that they're having heart disease. So I've seen, unfortunately, many young men, 40 and younger, who end up expiring because they just could not believe they could have heart disease, and they believed that their pain was more stomach or gastrointestinal, and did not consider heart disease as a risk factor for them. And like I said, a large number of patients have premature heart disease. We understand the 75, 80-year-old man and woman who have heart disease. That's just, people accept it, right? But we don't accept the 20, 25, 30, 35-year-old men and women who develop heart disease. And we see that the majority of people who have heart disease under age 40 are our people, period. So starting early and aggressively is so important in this, because we develop, based on our genetics, premature atherosclerosis in many sub-studies looking at. So like I said earlier, India, and by India I mean South Asia, accounts for more than 60% of all the heart disease patients in the world. 100 million. 100 million. Coronary heart disease rates among overseas Indians are about 1 to 4 times higher than people of other ethnic origins. And if you look at 1968, if you look at the West and India, we had heart rate, CAD rates, coronary artery disease rates about the same. The West has halved it. We have doubled it. There's a disconnect here. We need to work on fixing this. The average age of the first MI has decreased by 20 years in India. 20 years. This one blows me away because I was born in New Delhi. I left when I was 5, but the prevalence of heart disease in New Delhi is 10%. 1 out of 10 people. If you go to a movie theater with 200 people, you can guesstimate that 20 people in that movie theater have heart disease. There's a 5 to 10-fold higher risk of heart attacks and death in people less than 40, more severe heart disease. And despite the fact that we have lower prevalence of conventional risk factors, we don't have as many hypertensives, obesity, cholesterol. We say we're a vegetarian, although I call it contaminated vegetarian. So I love my patients who say, well, doc, I'm a vegetarian. So I'm like, what do you eat? Well, my wife made pakoras the other day. I love my mulika paronta. I'm like, but that's contaminated vegetarian, because you're eating a lot of fried foods, despite the fact that you're using the mantra that I'm a vegetarian, therefore I can eat anything. It doesn't work. It does not work. Well, let me leave India then. Maybe I'll do better if I leave India, come here. That's not true. The first generation immigrants are generally intermediate between those from where they came and the country of immigration. And that, like I showed earlier, has been going up over the last several years. And whether you compare it to our colleagues, Chinese colleagues in Singapore, we're dramatically elevated at all age groups. Women are not immune. Women are not immune at all. There's an excess burden among our female family, and we have a huge problem among Asian women too. So you're not immune. I can tell you how many Indian women and Pakistani women I've stented over the last several years. It's mind-boggling. These are our major risk factors. Okay, smoking, diabetes, high cholesterol, hypertension, low HDL. Low HDL is our biggest problem. So despite the fact that I exercise 4 days a week, I can't get my HDL above 45. Family history, age, all these things. But now there are newer risk factors that we look at. Coronary artery size is a big issue. Inflammatory markers like CRP and homocysteine, inactivity, lipoprotein A, which is a subtype, and of course, metabolic pre-diabetic syndrome plays a big role. Bigger is better. If you look at the data, and this is something that I've been working on for quite some time, and we published this paper in the American Journal of Cardiology, that if you take a man or a woman, a Caucasian man or woman, and an Indian man or woman, same height, same weight, corrected for body surface area, our arteries are significantly smaller than the arteries of our Caucasian friends and colleagues. That's a huge problem because less atheroma burden can make it occlusive for us. So what I do in my cath lab is minimally important. What we do at home and what we do in our doctor's offices in terms of medical therapy, in terms of exercise, diet, stress relief is more important. And we have to work together. Otherwise, we're sort of disjointed and does not work. Well, but the physicians must be really smart, right? Who come to the US, they probably doing the right thing. But there's a paradox. Asian physicians in the US have a 4-fold higher prevalence of heart disease compared to Americans, which is crazy, although they have similar or lower prevalence of all risk factors except diabetes. So that doesn't work. So what are our therapeutics available to us? Well, the treatment needs to be tailored and different from Caucasians. So, my grandmother, my daddy used to say, if you eat a lot of rice, your stomach comes out. And she was not a scientist, but she was right. I know when I eat a lot of carbs, my stomach goes out, as opposed to the Caucasians, where they develop the pear-shaped, where their buttocks gets larger. So it's a little different. The insulin resistance is more from the apple-shaped or the stomach. And so having a large belly increases your risk of developing insulin resistance and then either metabolic syndrome or diabetes. And that is what is important, because metabolic syndrome can affect so many other things besides just pre-diabetic insulin resistance. And we can go over this for hours, but in the interest of time, I'm not going to delve into it. But the reality is that we have to watch our diet. We have to have a more protein-based, less fat, less carb-based diet, more grains, more vegetables, more berry-based fruits. I love my Indian mangoes. The Alfonso mango is probably the best mango in the world. It is pure sugar. And the excuse that, well, it's fruit sugar doesn't stand. Maybe fruit sugar is better than processed sugar, but it's still high sugar content. And it's important to be careful. Whether you eat meats or not is irrelevant, but more protein is so important. Lentils, dals are so important. Nuts, milk, yogurt are very, very important. And decreasing ghee and coconut oil and sweets is very important, because even in the Lancet in 2002, they said that the use of statins, because everyone says, okay, I'm on Lipitor, or I'm on atorvastatin, or I'm on rosuvastatin, or I'm on Crestor, or Pravachol, or any of the statins, and they assume that's the right therapeutic to use. But I told you earlier that the LDL is not really elevated in most of our people, so it's less of an issue. And using other therapeutics, early modification of lifestyle, niacin will increase your HDL. Fibrate levels can be beneficial in that situation. And trying to get your LDL less than 100, with the assumption that you're not a diabetic, but for diabetics, we try to get our LDL lower. And the same we should hold for South Asians. And we have to sort of watch our intake of fried foods, the butter, ghee, the sugar, the salt, the portions. Oh my God, I was at a wedding last night. The portions are crazy. Eating late, we should not be eating food after 7 or 8 p.m., period. Because if you eat at 10 or 11, that food stays in your stomach all night and it gets transferred into fats. The snacking. Oh, I love my snacking, but that is probably the worst thing. Eating balanced meals over the course of a day is probably more important. And mitigating the excessive alcohol intake is so important. So the National Cholesterol Society recommends that 50% of our total calories should come from proteins and carbs, with 25% from fat. Asian Indians consume more fried foods and higher fat content than our colleagues. And the quality of the fat is equally important. Kerala is renowned for coconut use in India and coconut oil use, and has the highest incidence of heart disease in India, because coconut milk and oil has 92% saturated fats, which is the worst type of fat. The polyunsaturated or the monounsaturated fats are the ones that are good for you. The olive oils, the canola oils, the avocado, the nuts are what's good for you. I've already discussed with you the contaminated vegetarianism that we have in our country. We can't use the excuse, I'm a vegetarian anymore, because eating right is not just about eating fruits and vegetables. It's about eating the right type of fruits and vegetables, and the right cooking of the fruits and vegetables. Exercise is so important, and because the expression of the genes key to fat metabolism is lower in the muscles of our South Asian family and friends. So if a South Asian man and a woman and a European man exercise alongside each other at the same speed, the South Asian's muscles will burn less fat than the European. So it's important we do a little more than our colleagues from Europe or the West. In 2018, the cholesterol guidelines included South Asian descent as essentially a risk factor, like we have for heart disease, kidney disease, family history, diabetes. Now, if you're South Asian, that is a risk factor, which is so important. So what do we do? Common sense. If I tell you you should only eat boiled vegetables every single day and berries for dessert, you will fail. I will fail. But what I will tell you is that we all have our cheating diets, right? I love ice cream. My biggest vice is ice cream. I can eat ice cream all day, and my wife knows it, and so she hides it. She doesn't buy it anymore, because if she buys it, I will eat it. But I also know that if I eat heavy today, like last night I was at a wedding, today I'm going to compensate. I'm going to have more protein. Today I'll have 2 eggs, in the morning, no bread. I'll have a protein-based diet today for the next several days in compensation for what I've done. I'll eat more salad, more chicken, more fish, because I do eat meat. I try to mitigate my red meat intake. So these are all things that we can do as a group. We can exercise more. What is exercise? Well, exercise is, to simplify it, if you take 220 minus your age, so I'm 55, right? So 220 minus my age is 165. I want to hit a heart rate of 70% of that for at least 10 minutes, 3 times a week. That's just a simple way of saying, if I hit my heart rate above 120 for 10 minutes, 3 times a week, that is aerobic exercise for me. Everyone has different ages. Everyone has different capacities. You need to build up to that. So it is important to exercise. Most of us here are first or second generation from India or Pakistan or somewhere else. And the stress that we have is extraordinary. Whether we're physicians or whether we're running a business or driving a cab, there's a lot of stress. We have to find ways to mitigate stress in our lives. And it's easier said than done, but it is of paramount importance. Now, like I'd mentioned earlier, I'm the president of the Long Island American Heart Association. And so because we have seen so much heart disease among our people, I started this South Asian initiative where we provide automatic external defibrillators to places of worship, agnostic to what it is. We've given to mosques, we've given to mandirs, we've given to gurdwaras. And, I'm not sure if you have it at Flushing Hospital. If not, we will be happy to provide you with an AED. But it is very, very important to have them available, because we have seen too many situations where patients have sudden cardiac arrest, even at places of worship. So it is very, very important. Because I see so much heart disease, I did a CT angio myself, and fortunately I have normal coronary arteries with no calcium and no significant atheroma. So far, so good. Please get the message out as much as you can, because it's important. That 1 or 2 visits a year where you try to eat really well for 2 days before your blood work, or 3 days before your blood work, and then after the blood work is done and your blood work looks relatively okay, you go back to the old ways. That's not the right thing. You need to have a program that's sustainable over the course of years, and that is what's important. Anyway, I thank you very much for allowing me to speak. I was told to finish in 35 minutes, and I actually did. So I'm happy to answer any questions. Dr. Sai, Dr. Uma? I think you're on mute.
Actually, I have no words, Dr. Jauhar. I mean, some of those startling facts, it's unbelievable. I knew a lot, okay? Being a practicing cardiologist, especially clinical cardiology, we see so much of it. I know that 90% of the information, I don't see, we come from ancient history, Indian history tells you, actually the whole world is following yoga practices, correct?
Absolutely.
Which only dictates to you proper exercise, proper diet, and relaxation techniques. And what has happened to our population that we just kind of give up and not pay any importance to that? So, I mean, it's not a question, it's a comment, but please take up from that. And what was startling to me is when you said about the food in so many different ways. I think, do you think as a community, as a society, that we should go to the Apna Bazaars and the Patel brothers and tell them, look here, you have to have a separate section where you can actually promote some healthy diet. So we also give very good food in our cafeteria and canteen, but we do have some healthy diet tips, and have some posters and some facts that it's unbelievable how you said that, we are like, 100 million cases of coronary disease and 4 times more than Americans. It's a very, very startling fact. It's amazing. Some of the stats that you've given are like really, wow, it shakes you up, So
you're right. You're 100% right.
Probably because you're in Long Island and you're so closely related to American Heart Association, and with the Uma's permission, we think that we hope that, with your help, we can have a collaborative effort to the community and have these startling facts somewhere along, put them in like I said, where people go to buy their grocery. Just as you see, 90% of the store is covered with all the goodies that you've mentioned. Maybe there's actually he sells those little sprouts, the mung sprouts and all those things, I think are the best thing to eat in the morning, and with some, dates and stuff. But who wants to eat all that? But like you said, maybe once a month, once in 2 weeks, you want to enjoy, cheat, go ahead. But you know what, 90% of the time, if they actually listen to you carefully, it's a life and death situation. I think we have to pay more attention to diet, obviously exercise. I thought the first or second generation in the US would be more aware of the facts that you've given. But I think the stats are very scary, to be honest with you. And the masala study especially, like you said, I love the word contaminated vegetarian. I know they said, but you're vegetarian, you will never have a heart issue. But that's not true. All the snacks and the deep fried food, my God, is not good. So I would like to ask you a question since we are in this pandemic thing. Can you please tell us, I know you've done so many studies and in the recent past, the COVID related questions on the heart quickly, and then we'll go on to the other questions that I have here.
Perfect. No, look, COVID has been a disaster, right? And it's been a disaster, not just because of the infection, but because of the fear of the patients for getting primary care. So there's several factors that play a role. So COVID in and of itself has probably limited effects on the heart per se, but it does have some, and I'll talk about them in a second. But what it has done, it has prevented patients from going to see primary physicians. So as we come out of COVID, the volume of procedures that I've been doing in the last several months, as we've gotten out of the Delta and the variants, all the variants, has been dramatically increased. And I subscribe that to the fact that people just did not take care of their health during the COVID pandemic. They didn't get the blood checked. They didn't really take the medications as thoroughly. They didn't exercise. They ordered Uber Eats all the time. They stayed home. They were fearful of leaving the house for exercise. Irrespective of gyms that were closed, I had patients who said, I just didn't even leave my house for a year and a half. I never walked, I never exercised. So we're seeing a lot more heart disease. So that's the one side of it on COVID. The second side is COVID. There is an association with COVID and certain arrhythmias, myocarditis, although very rare. There are patients who have developed infections of the heart with COVID based. And so that is definitely an issue. There's a long COVID syndrome now that's coming out. Patients are tachycardic, or they're fast heart rates. They're fatigued. They're getting palpitations. So there are a lot of factors that do play a role, but I think the worst thing with COVID was that patients just did not go see their primary doctors. But to go back to your first point, which I think is so important, is, the Indian culture is second to none, right? Our ancestors taught us so much that we just did not listen to them. If you go back to the original stuff on yoga, in terms of stretching, breathing exercises, walking, there was no cars back then. You just walked everywhere, so there was inherent exercise. The yoga exercise that we do now, people, what I find humorous is that the Americans are more in touch with yoga than we are nowadays. And that's sort of, I find that embarrassing. My wife does yoga every single morning, and touch wood, she's very healthy because she spends that 20-30 minutes every single day on yoga. And I think it mitigates stress. It improves stretching. It works your core muscles. The one thing that happens to all of us as we get older is that our core gets weaker and our flexibility gets less. And there's nothing that improves flexibility more than yoga. So anyway, sorry, you asked a question.
Your apology. Let me introduce Dr. Uma Mysore, who's our beloved president. It's unbelievable the way this institution is managed and run. Uma, if you can unmute yourself, is really so crucial to really see what Uma does single-handedly. Somebody called her a single man army or single woman army, and she's taken up so much responsibility. It's a special community service that she has done.
Uma is a legend in the community. She's a legend. We all know Uma.
Thank you, Dr. Jauhar. Appreciate it. I suppose, can you hear me now? Can you hear me now?
I can hear you, yes.
Her dedication and commitment are like unmatched. So let
Absolutely.
me introduce Dr. Mysurkar at this moment. I'm so sorry. I didn't realize she was on video and audio from the
Okay,
beginning.
that's all right.
Go ahead, Uma. Do you want to say
don't
something?
need
I have
any
several
special
questions, but I'll
introduction,
come
right?
back to that.
I'm very pleased to see Dr. Jauhar, and certainly I think, all these things brings me back into our med students during the time, what we were taught and what we should do. And as you very correctly said, our whole life system has changed. It has become so fast that everybody wants to eat the fast food because you want to get here, get there, get there. And I think that has certainly ruined many of our own health. And it's time now, just like everything has evolved, it is now time to go back to the original. As you just ended that, how our ancestors did, I think those things need to come back and re-emphasize from young age onwards. If you introduce this at our age, nobody's going to worry about that. Nobody's going to care. But I think this needs from the very beginning. I sincerely hope they could do this in school curriculum. You see, if they did that in school curriculum, emphasize on health, exercise, diet. It doesn't matter vegetarian, non-vegetarian, but be the right diet. And I think we can improve the health of the population so much.
Absolutely.
But unfortunately, there is much more to worry about in this world than the health it looks like at the moment. But we should continue to try, and I certainly agree with Sai that at least at the temple population, we should try and at least bring awareness of health, awareness of what they should do in terms of the diet, in terms of exercise, and have some experts like you when things get better to actually come here and talk to them. So it's much more than on the Zoom, just to sit across and say, look, this is how it is, show them the statistics. Even if we can help 10 people, I think we have done some service. And I really want to do that, really, because I see many times I heard every second day when I come to the temple, somebody says, so-and-so is sick, because he is admitted to the hospital. This has become so routine and so common that it is kind of depressing. Young people, 50, 55, and it's sad that this happens. So this is something we'll learn. I hope this message went across who are on the Zoom, and then subsequently those will go on the YouTube also. And but I think we need to bring in more educational things like this so that people can get the awareness of it.
What's interesting, I find interesting, is that, we talk about vaping, right, among our kids, and how it's a tragedy, and we're trying to stop the vaping, and people are so aggressive, and there's now initiatives across the in Congress and others about to mitigate vaping. That's a small number. The diet plays a huge role, and what you learn as a child is what you maintain the rest of your life. It is so important. In our hospital, we've stopped sodas, so you cannot buy a Coke or Diet Coke or Sprite at North Shore. It's not available because they've decided that drinking these sugary drinks are not good for you. So we have water. We have water or healthy drinks at our hospital, and it is so important. And what you said, it cannot be overemphasized.
What surprises me is that in schools, they provide lunch. And I remember during the pandemic time, they were showing what lunch is. And I was amazed. They have a lot of health inspectors and all that. How can they provide lunch which was so bad for these young kids? It was all filled with carbohydrates, nothing else but carbohydrates. That is really, at least in the city schools, they should be able to provide much better than that. But that was very shocking to me. I was even speaking to some of the parents, and they were also very disappointed. There's nothing much they could do. So I think all in all, everybody needs education, awareness. I think this particular portion has been neglected. Thinking that, it's okay, he's old, it runs in the family. It's just become like a common talk and not paying attention to what we can do to prevent it. And in fact, we can do to prevent it. And at least to delay. I mean, all of us are lesson, but something we can do.
Appropriate, Uma, if I may, Dr. Jauhar, with your permission. I think Dr. Valentin Fuster, you know him, the master of cardiology at Mount Sinai. He always talks in his conferences that he conducts in Manhattan once a year about starting in schools. And he's done a lot of work in Spain and other countries, in African countries. I was always thinking, can we do something in India? But it was so difficult. I went to my hometown and district, forget about the politics and to start anything over there. Now it brings back to me what Uma's saying, why can't we do it here? Maybe we can start a mini project, Dr. Jauhar, with your help, just educating our adults first. Maybe then we get to the school levels, because we'll have to have connections and politicians and everybody else gets involved. And this so-called vegetarian uncontaminated diet, we can call it, and see if we can have a little separate area in, you know, and especially every other Indian that's in, I mean, a South Asian descent goes to Apna Bazaar or Patel Brothers. I think the schools is one thing, the community centers are another thing. So if you have the mental energy to kind of collaborate or coordinate something, we can sit down and talk to Uma. I was very scared to look at the stats. I mean, I do take care of patients, but some of these stats are really touching. And I have a couple of questions from the audience. I don't know if you want to think about it and give us your thoughts back, but to the question I asked Dr. Jauhar, to help the community of different age.
You know, if you go to Whole Foods right now, you will, and you go to the bread section, you'll see 35 different types of bread. Some are bad for you, but you also have the multi-grain and everything. If you go to, and I'm just gonna randomly pick a store, Patel Brothers or Upna, whatever, it's agnostic to that. You'll get 2 or 3 choices, white and wheat. That's all you get. You don't get these at least I don't see them. Or
rotis there.
Rotis are there and the naans and stuff, but you know, and then you walk around and you see these amazing ice cream. I mean, the ice cream section in Patel is wonderful. I mean, because, you know, I live there, right? It's my favorite place in the world. So they have they have a couple of huge areas just for ice cream. And you don't have the low carb ice cream that you can buy in the US, as an example.
Economy, everything is economy, you know. See, for a store like that, they're not really interested in, to be honest with you. I think they want to sell their product, you see, and it's very difficult for us to go and say, don't do this, don't do this. They just won't listen, because they listen, as long as it is permissible by law, we will sell it. That's it. That's how it is. Because I know I did have some kind of light discussions with some of these people, you know, and that's how they say, and I can't blame them, because everybody has to make a living. They say, so we sell what is right. And they have to make a choice, what they want to buy, they don't want to buy, it's up to them.
But I think education is where you start, right? You start it early. Education, teach the kids exactly what is good and bad. That does not mean you don't eat donuts or bagels. I'm not saying that, but you mitigate that and you eat it in the right portions. Everything's about portion control. You can eat everything as long as you have portion control. If you like your donut, have a donut today, but then compensate tomorrow, you know, with a salad or egg whites or something else, you know. So it's all about that. And unfortunately, we don't, I'm the worst of that, but although I've gotten much better at doing that, but it's important.
We're going to need 2 hours at this rate just for diet alone, Uma. But I think we'll have another session with Dr. Jauhar. But I think I have some questions.
Please.
What I was thinking is, instead of telling them, don't do this, don't do that, we'll tell them in a positive reinforcement way, have a heart healthy center and somewhere in one corner or somewhere, just say this is heart healthy. You know, these are the foods that have Indian origin that could be healthy to the heart. So that might work. So now we're getting to the questions. If the little lipoprotein little a is high, what do you recommend? This is a question from the audience, Dr. Jauhar. So
lipoprotein A, well, there's certain drugs coming out that will be beneficial, but niacin does play a role. Niacin is a good drug for lipoprotein A. Statins have some effect on lipoprotein A, depends on how elevated it is. But niacin is probably the cheapest and the best drug available to us right now.
Okay. You don't believe in folic acid?
I do. I just don't think it's
It-
as beneficial.
yeah, it doesn't tell you, okay. And a related question, how does niacin that was mentioned help beyond or instead of statins if a patient needs this?
Well, niacin, like I said earlier, it can help raise your HDL by like 10 to 12%. And every 4 deciliter increase in HDL, 4-point increase in the HDL decreases your heart risk by several percent.
Now, how low LDL should be in diabetics? What does low LDL mean and how high should the HDL be?
Well, low is less, I mean, you want it less than 70, right?
70.
70. You have to assume they have heart disease. And so getting in less than 70. What is too low? Too low, there's really no official number, but I would argue anything less than 30, 40, 30 is probably too low, but there's no official number. In terms of HDL, menstruating women can have dramatically elevated HDLs. My wife's HDL was 105, which is perfect. When your HDL is above 60, it's a negative risk factor. So if you're hypertensive and diabetic and your HDL is more than 60, then you take away one of the risk factors. So it takes away one risk factor. So it's a very positive thing to have the highest HDL possible.
That came from that kind of topic from the audience. Now, I was reading your CV. You worked a lot on nanotechnology in cardiology. Could you just elaborate on that? How does nanotechnology work in cardiology?
It is still at the nascent stage. So I don't think it's ready for prime time yet. But nanotechnology has been useful on some of the stents we use to prevent platelet aggregation. But it's not ready for prime time in terms of lipid therapeutics.
But the Raju and Kalam stent in Hyderabad that was created, but I think with that in mind, but they didn't go too far. What do you think the difference between the stents used in India, of course they use some of that are produced here, manufactured here, and versus the stents used in the United States?
So I actually go to India once a year, pre-COVID, and I run a course in Mumbai. And I can tell you without a doubt that cardiology care in India is at the highest level of anywhere in the world. The equipment they have is as good as, if not better than any equipment we have in the US. The stents they have are the same, but they have more options in India than we have in the US. So we have in the US essentially 4 stents available to us. India has 14. So, healthcare in India is terrific. If you have money, healthcare in India is terrific. I'm going to be going to Chennai in December to give a few talks, and then I'm going to travel across the country to do procedures in low-served areas. And I can tell you that healthcare in India it blew my mind away when I went for the first time several years ago. And every time I go, it's bigger and better.
I think the most developed specialty is cardiology, and most
Absolutely.
of the corporate hospitals survive on cardiac cases.
Mm-hmm.
Yeah.
Especially the major cities. I mean, Mumbai, Chennai, Delhi. I mean, Delhi has some of the most amazing centers. I mean, I know all the interventionalists there, cardiologists there. I know a lot of them, and they're better or as good or better than anyone here in the US.
You go to Chennai a lot because I see that you've been awarded by the Tamil Sangams.
Do I go to Chennai? I don't go a lot. My sister got married in Chennai, so I guess I have been there. This year, there's a cardiology society in India, in Chennai, so I'm going there to give some talks. But I go all over India.
The other question, generally, when we have the mini health fair and all, they ask, the stents question was answered. The indications and the quality control. You know what happens when they go to these big hospitals? They say, okay, just for diagnostic coronary angiogram, it's $1 lakh. If you pay 3 lakhs, when we find something, we're going to dilate and stent it. Do you think that it's appropriately being, the care is being delivered to patients?
So I can tell you that at the major centers in India, it is. I can't speak for all the centers, but I can tell you that the major centers do it very academically. You know, if I see a blockage, so if I see a blockage at 70%, maybe you'll say it's 80%. Dr. Uma may say it's 60%. And so we don't really have a metric to assess it angiographically, but we have a lot of technology available to us that is used all over India to assess the physiology. So we need to make sure that lesions we're stenting are appropriately stented. So just because we have a blockage does not mean it needs to be stented. Only if it's physiologically significant do we deal with it, whether that's on a stress test or whether we use some provocative measures that are in the cath lab. That's different.
What's your idea about the FFR in the cath lab and there's a questionable lesion?
Use it in all my cases.
All your cases.
Any case that I'm not sure needs a stent, I always do FFR, IFR, because that will prove to me yes or no.
The general audience, for them to understand, can you please explain what FFR means?
Sure. It's basically, if someone has a blockage, are they getting the blood flow to that muscle, that area that's supplied by that blockage? And if they're not, then that needs to be opened up, because then you're getting less blood flow, less oxygen. So what FFR does, it checks the pressure beyond and before the blockage. And if there's a significant difference, then we put the stent in. If there's no significant difference, then we do not put a stent in. In other words, if the pressure beyond the blockage is essentially the same as the pressure before the blockage, then the blood flow is not being restricted.
By some numbers, which is consistent.
Yeah, and there's numbers. I mean, we don't need to go through the details, but we have created these sort of research models that say below this is when you fix, and above this you would not fix.
This is such a popular topic. Can we go with a few more questions in the interest of time? I have several over here.
Please.
Maybe 5 to 10 minutes if Dr. Jauhar is available. Yeah.
I'm free.
Okay. With Dr. Uma's permission, we'll take at least a couple more. The management of acute MI, we saw most of the hospitals, I guess it was out of fear. Acute myocardial infarction for the general audience means a heart attack. There was almost like a sudden decrease in the patients that came to the emergency room. And was there a difference, something related to COVID out of fear, or how did we take care of our acute MI patients during the pandemic?
So, you know, if you look at the data, and we published this paper in Journal of American College of Cardiology, on a given day, we get a couple hundred 911 calls per day. During the peak COVID, the number of 911 calls dramatically increased. And the 911 calls that were sudden death dramatically increased. In other words, patients were so fearful of COVID that they would stay home in heart failure, they would stay home with the palpitations, they would stay home with chest pain. We saw that patients who actually came to the hospital, and because I was in the hospital every single day during COVID for that 2 years, and I saw patients who actually came in sicker, with more heart failure, with more blockages. They wouldn't come for the routine. And we saw a lot more sudden death at home than we've ever seen our whole life in my career. And that's numbing, that people actually were so scared of coming in that they just would not leave.
Now talking about a little bit technical, because there are some doctors.
I'm sorry, I can't hear you now.
Can you hear me now?
Now I can.
Okay. Now, there are some questions because it could be a few physicians in the audience. Left main disease, which generally is a concept that, it has to be bypassed. Now, what's your idea about stenting a left main, which for the information for the audience has to understand that it It provides blood to at least 2/3 of the myocardium, to the heart muscle. So they always thought that doing a bypass surgery was the appropriate thing, especially with the ejection fraction, which was a little lower. What do you think with all the advent in cardiology? I see more and more people going for stents.
So, that's a question that we could spend a few hours on, but the reality is depending on the location of that left main blockage, number one. Number two, whether there are other blockages around. Number three, whether what we call the syntax score, which is a score we look at on the anatomy of the vessels to see if it's high or low. If it's low, stenting may be equivalent to bypass. I still think a bypass is probably the procedure of choice for people with left mains, but it has to be individualized.
So correct, Dr. Jauhar. Now, we also came across your CV saying that you were involved in intracoronary brachytherapy. Would you please tell us a little bit about brachytherapy in coronary artery disease?
Sure. Brachytherapy is basically radiation to the arteries. And so with stents, about 8 to 10% of patients with stents develop what's called neointimal growth. It's like a keloid. When some people who cut have injuries to their hand or skin, they develop this keloid, this sort of tissue growth over that. The same thing happens in the arteries. And so we use radiation within the artery for people who get that re-narrowing a couple of times to prevent that re-narrowing from occurring again.
And, being an interventionalist, obviously you would like to favor stenting, but using your judgment based on some studies, especially the COURAGE study, in somebody who's fearful of going for a stent, would you encourage intense medical therapy?
That is a no-brainer. I mean, obviously, that slide I showed with the CPR, I do not improve survival, except if you're having a heart attack or you're having really unstable symptoms. I do not improve survival. It's the medical therapy that improves survival. The beta blockers, the statins, the aspirin in certain situations, the ACE inhibitors. That's what improves survival. Exercise, losing weight. So what I do is I improve awareness. It's amazing that patients who have a stent or have an angiogram are more likely to be aggressively medically treated than someone who's not. So instead of taking your medications as needed, they take it every day. And that's what's important.
It's so refreshing to hear from an interventionalist, Dr. Jauhar. I think that's basically, we do have some more questions, but in the interest of time, we really, on behalf of the Hindu Temple Society, would like Dr. Mamai Surkar to make some closing comments. And we are really proud of your accomplishments, Dr. Jauhar. We must invite you for another one. And I'm looking forward to working with you to do something for the community.
It'd be my pleasure. By the way, I have a quick question. Do you have AEDs at the temple?
Yes, we do.
Perfect.
But we can use an extra one, right, Omar, if Dr. Jauhar is willing to give us?
Sure. Yeah.
Yes. So we'll talk about it offline, but yes, we will get you one.
Sure.
Thank you. On behalf of the Hindu Temple Society, I will thank you immensely, Dr. Jauhar, for a very educational and a topic which is so common and yet so complicated and yet not followed well. I mean, everybody knows what is right, but difficult to follow because of our food habits and our day-to-day habits. But I think the emphasis that was laid on the diet and on the exercises was well appreciated, and hopefully a message has gone out, and we see many more questions pertaining to how they can do this. And as Dr. Sai said, we must have more educational seminars such as this, hopefully sometime face-to-face, because they get more connected to the speaker when you're sitting there face-to-face. Yeah,
Absolutely.
so it's good. Certainly Zoom is good, but I think it's nice to have a face-to-face. And then people can ask questions and clarify, and they really feel well when they speak to someone who can clarify the question. So we'll do that very shortly. Thank you very much, and all the best. And
Thank you so much.
Thank you so much.
Appreciate it.
Thank you, Sai. Thank you.
Bye-bye.
Bye. Thank you.